Hi, this is Miss James. We're okay. A woman with class 2 heart disease would have symptoms with increased activity, and we talked about this yesterday. Yes, she would, because class 2, she's having a little bit more problems with the heart disease. When assessing a pregnant woman with iron deficiency anemia, what would we expect to find? Iron deficiency anemia, as we talked about, has to do with oxygen carrying capabilities. So, what would we see? Would her mucous membranes be pink? No, they would not. Would she have an increased appetite? No, sometimes they are at risk for anorexia. Would they be fatigued? Yes, they would. Bradycardia really wouldn't have much to do with iron deficiency anemia. So, the answer is fatigue. Malaise, weakness, anorexic, they're very susceptible to infection, frequent colds, mucous membranes are pale, and they may be more tachycardic because they don't have good oxygen carrying capabilities and more tired. All right. A woman who's HIV positive has to go undergo a cesarean birth. There are mixed feelings about this. Um, According to the literature, she doesn't necessarily have to, but it is highly recommended. Um, this is based on her viral load, if her membranes have already ruptured, and how the labor has progressed. We're hoping that if we know that she is HIV positive ahead of time, that we can go ahead and take care of scheduling a cesarean to protect not only mom, the baby, the staff. I'm talking about. Um, we're not doing this critical map this time. Ms. Bradford will be discussing with you HELP syndrome, so we aren't going to be going over that. Diabetes is a complex disorder, and like we talked about yesterday, it is an alteration of carbohydrate metabolism. It's either a partial or a complete lack of insulin by the beta cells of the pancreas, and without insulin, the glucose accumulates in the bloodstream, and this is what causes hyperglycemia. You should have gone over a lot of this in MedSurge 1. The symptoms for diabetes mellitus: polydipsia, polyuria, and polyphagia. If she is diabetic in early pregnancy, there'll be just a small change in the maternal need, and as she progresses, this will only accelerate. The insulin is released in response to the serum glucose levels, and this increases. And because the insulin response is different, sometimes she may develop hypoglycemia. Later in pregnancy, fetus is growing, needing more glucose, and there's a rise in the placental hormone levels. And these hormones are what cause a resistance to the insulin working as it should. During birth, mom will return to normal glucose levels, and it is essential to reduce the potential for neonatal hypoglycemia. Postpartum, her need for insulin will generally decrease, and she should return back to her normal insulin needs. Breastfeeding is encouraged. The added caloric intake by the mother helps to lower the amount of insulin that she's going to need with both type 1 and sometimes type 2 diabetes. Gestational diabetes usually needs no insulin, like we were talking about yesterday, after the baby is born. Diabetes mellitus, you've already learned it's type 1 and type 2. There's an impaired fasting glucose and an impaired glucose tolerance. And then there's also gestational diabetes. The classifications during pregnancy, you'll see this in your textbook, is called pre-gestational diabetes. These are usually your diabetes mellitus individuals. or gestational diabetes. During the first trimester with diabetes mellitus, the mom may experience hypoglycemia, hyperglycemia, or ketosis. There's an increased incidence of spontaneous abortion or major fetal malformations depending on how mom's management is and how we call them brittle diabetics, how terribly glucose impaired she is, how dependent she is on insulin. Preeclampsia is 2 to 3 times more likely with this individual. As you already know, individuals with diabetes mellitus have an increased risk of hypertension, heart disease, and other issues. She's at risk for premature rupture of membranes, and the newborn has the potential for a large head, macrosomia. The fetal effects often with diabetes mellitus are congenital malformations. Sometimes that's why preconception counseling is important. We'll have variations in fetal size. The abbreviations are SGA, small for gestational age, IUGR, intrauterine growth restriction, or LGA, large for gestational age. And it's important to note that these babies run the risk of being hypoglycemic when they're born. So this is why it's very important that we monitor their Accutest. Hypoglycemia, hypocalcemia, hyperbilirubinemia, and respiratory distress syndromes are some of the effects that we may need to assess of a baby born to a diabetes mellitus mother. It's very important to get a good history on when did she become diagnosed with diabetes mellitus. Is she on insulin? And we may need to put her on insulin to help control her diabetes even during labor without no oral agents. These individuals usually require insulin. We need a baseline echocardiogram or electrocardiogram. We need to check her eyes and get a good baseline height, weight, and blood pressure. She'll need a 24-hour urine and an A1C, and this would be quite frequently throughout the pregnancy. As I was said before, preconception counseling, we need an A1C. It needs to be less than 7%. It is very important that these women understand that in order to have healthy mama, healthy baby, we need to maintain adequate glycemic control. This is very important. Nutritional management, any agents that she needs to have available should she develop hypoglycemia. She's under close maternal and fetal surveillance and close management during labor and birth. A lot of times they will be on an insulin drip because who's needing the glucose? The baby is. A good health history, a physical exam, and discuss the risk factors. A very thorough screening at the first prenatal visit, and additional screenings are conducted at 24 to 28 weeks whenever she's considered she's at risk. We're checking urine for protein, for ketones, for nitrates, for leukocyte esterase. We're evaluating her renal function every trimester. We're evaluating her eyes at the first trimester, and we're getting an A1C at every 4 to 6 weeks. For the fetus, we are conducting ultrasounds. We need to get an alpha fetoprotein at the appropriate time. She'll require a biophysical profile, non-stress testing, and sometimes amniocentesis is required. Gestational diabetes. During pregnancy, the risk factors are usually that she may be overweight, she may be older than 25, she may have had a previous birth that was associated with gestational diabetes. Gestational diabetes in a previous pregnancy. History of abnormal glucose tolerance. Whenever she's had a glucose tolerance test, it wasn't quite normal. Has had a family history of diabetes, or she's in a high-risk ethnic group for developing gestational diabetes. And these are just the usuals, and this doesn't mean that if you're only in this risk group, that you're the only ones that may end up developing gestational diabetes. A glucose challenge test is often done at first. It's a 1 hour test. She does not have to be fasting. She'll drink 75 grams of oral glucose solution, and then her glucose will be tested an hour afterwards. If it's abnormal, then she will need the 3 hour oral glucose tolerance test, where she drinks 100 grams of the solution, and this is whenever she is fasting for this. The normals, and you'll see these in your book because depending on the lab, these could be at different ranges. A fasting glucose should be less than 90 to 92. An hour should be less than 180. After 2 hours, less than 153, and after 3 hours, it should be less than 140 to see how she is metabolizing this high glucose. Diet, it's important that with gestational diabetics that we have them meet with a dietitian to help them know what they need to eat. Non-obese pregnancy weight in an average of 30 kilocalories per kilogram per day is recommended. If she's obese, she needs to cut it back to 25 kilocalories per kilo per day. Exercise is still important. That's safe for the pregnancy. Blood glucose monitoring, will be doing it more frequently, as well as fetal surveillance. Okay, so once again, this is the same thing as I showed you earlier, what we would need for a woman with a pregnancy and diabetes. This is a repetitive skill. Okay, she's 26. She's a G1P0. She's at 6 weeks of gestation, and she has type 2. Her BMI is 32. Her A1C is 9. And remember what we said it needed to be. She takes an oral glyburide at 10 every day, and the physician has placed her on insulin at this time. So what is our priority? She's apparently type 2, and she's 6 weeks pregnant. She's only 26 years old. She's got an A1C of higher than 7%. So what does that tell you? So what is our priority? We need to give her effective education about using insulin, her diet, and her exercise, because we want her to maintain normal glycemic control as soon as possible. And timing is of the essence because she's entering into the period of intense organ development. Elevated blood sugars are correlated with serious fetal congenital malformations. So, once again, appropriate, adequate glycemic control during the first trimester to reduce the risk of malformations. What do we need to teach her? Think about everything that you know about insulin. Sometimes, I'm sorry, let me get some coffee. Insulin needs sometimes decline during the first trimester and then increase during the second and third. Why? Baby is developing more, baby is requiring more insulin, and sometimes nausea and vomiting. We have some emesis issues cause a decrease in the insulin needs. In the second and third trimester of pregnancy, human placental lactogen is produced by the placenta. This causes more of an insulin resistance. Therefore, we need more insulin because we need insulin to metabolize the glucose so it gets into some form that the fetus will need for development. Think about everything rationally. What additional risk factors does Susan have? Obesity. She's large. Remember her BMI. It's associated with many maternal and fetal risk, including increased incidence of fetal anomalies, fetal death, macrosomia, shoulder dystocia, which we learned about before, hypoglycemia, and often sometimes stillbirth. Mothers are at increased risk for diabetes, preeclampsia, postpartum hemorrhage, and delayed lactogenesis too. You can look that up. Bottom line is, if she's obese, she's at more risk for a lot of issues. How should she be counseled about her weight? What did we say? Calories per kilo. She should only gain between 11 to 20 pounds during her pregnancy. It's recommended by the Institute of Medicine, and this depends on her pre-pregnancy BMI. 35 to 50 calories per kilo of ideal body weight. Much of this is complex carbs, proteins, and unsaturated fat. This should be distributed between 3 meals and 4 snacks. We need to teach her about a hypoglycemic reaction. Now, in your book, it talks about eating 2 crackers followed by 8 ounces of low-fat milk. We're very careful about orange juice anymore. If she has something that's a complex carb like crackers and low-fat milk, it's going to stay with her longer than drinking fruit juice. Signs and symptoms of ketoacidosis that you should have learned are fruity odor to the breath, nausea and vomiting, exaggerated respiratory effort, and altered mental state. What advice should we give her regarding exercise? Now, a big thing about pregnancy and exercise needs to be safe for her and the baby. If she's in good cardio health, it's recommended that she spends at least 30 minutes of moderate exercise on most days of the week, avoiding exercise in the supine position for the first trimester, and avoid any contact sports. Brisk walking and swimming are very good, but she does need to talk to her health provider before she takes on any exercise program. This will help control her weight, and what she needs to understand, it may decrease her blood sugar and allowing for lower doses of insulin, so she has to be aware of that. Delivery needs to occur between 38 to 40 weeks of gestation, so that because the control of the diabetes becomes more difficult during this time because the fetus is growing larger. We may have to place her on an insulin drip, take hourly blood glucose, because insulin requirements are less during labor. Even though she's on a drip, we're maintaining a glycemic balance so that the baby is okay and mama's okay. We check the urine for ketones, very close fetal surveillance. If she's diabetes mellitus, we continue to monitor blood glucose levels, ketones, monitor her for hypertension, uterine atony, and infection. We do want her to breastfeed. We need to talk to her about contraception after delivery. Diaphragms are often recommended. Estrogen containing birth control pills, which you may not know, and a lot of physicians or providers will not tell us, estrogen containing birth control pills will increase our insulin resistance, and IUDs increase her risk for infection. The baby, macrosomia, like we talked about, which is potential for birth trauma, intrauterine growth restriction, hypoglycemia, hypocalcemia, and they will present with jitteriness, hyperbilirubinemia, and polycythemia, congenital anomalies, infection, and often prematurity. This concludes our lecture on diabetes and pregnancy. I hope it helped enlighten you on some things. Please let me know if you have any questions, and I will be putting up a recording for chapter 22 hopefully shortly. Thank you.